Good morning to all. Let's start our session. I am happy that we have over 200 registered participants. I am Ioana Katsavou from Axia Innovation, and I would like to welcome you to the OActive training, aiming to inform end users on how biomarkers, biomechanics, and artificial intelligence can be combined to result in personalized interventions combating osteoarthritis. OActive is a Horizon 2020 project on advanced personalized multi-scale computer models preventing osteoarthritis. Today, presenters from the OActive consortium are gathered here to present the impact the OActive project can have. So before we start with the presentations, I would like to highlight some organizational points. As you all know, the session is being recorded. All participants have gone through the privacy policy. Training material will be developed and will be available through our website at oactive.eu. Please, all participants, mute your microphones and switch off your cameras to have better quality and avoid background noises. However, presenters, if they wish, they can switch on their cameras when presenting. Any questions can be asked through the chat only, but please state your name and your affiliation when submitting a question. Then presenters will be asked to provide answers after their presentation. We will have one break, but don't log out during the break to avoid delays. And at the end of the meeting, we will have an evaluation that will be done through the Slido platform. I would like now to invite Professor Kyriakos Felekis from University of Nicosia, the project coordinator, to take the floor and present in brief the OActive concept.
Good morning, everybody. I would like to welcome you also to this online training session. Unfortunately, due to the recent event, we cannot be face-to-face, but I'm very happy that we have a large number of participants to this session. My name is Kyriakos Felekis. I'm from the University of Nicosia. I'm the coordinator of the project together with Dr. Christoforos Giannakis, and I will be very brief, presenting you just the concept of the OActive. Very briefly, what we are trying to do. If you can see my screen. So the title of the session is, as Ioana said, engaging the end users to the OActive world. What we're dealing is with osteoarthritis. So osteoarthritis, as most of you know, is a degenerative disease of the joint and the most common form of arthritis that causes pain and mobility limitations. It's a very complex disease. It involves many factors, biochemical, biomechanical factors, and is the most important cause of disability in the elderly population. It's characteristic that up to 30% of people over 65 are suffering from this disease. And knee is the most commonly affected joint. So various factors like age, gender, hormonal status, BMI, family history, occupation, physical activity, past history of the knee joint, injury of the knee joint, and even depression can be some of the factors causing osteoarthritis. However, it's very difficult to define, predict, and even treat. So progression is purely understood, and that has resulted apparently in a lack of prevention and treatment interventions. So that's where OActive comes in, basically. That we're trying to implement a multi-holistic approach, incorporate various data from patients from various levels, starting from molecular, cellular, tissue, and whole body, integrate all this information into a computerized model, a hybrid model, together with environmental, behavioral, and social risk factors. And the aim is to generate robust predictors for new personalized interventions from delay the progression of the disease. So who we are? We're actually 13 partners from 7 different countries. We have 5 SMEs and 8 research institutions taking part in the project. The duration of the project is 36 months, and the total funding was 5 million euros. So what we try to do within these 3 years is to actually, as I said, combine various parameters and various data from patients from 3 cohorts that we recruited, one in Greece, one in Cyprus, and one in Spain, and from big data registries, collecting biochemical information, environmental biomarkers and behavioral modeling, biomechanical modeling and biomechanical data, all of them entering into a computational model empowered by big data and deep learning, basically. The model is validated at population level and at tissue level, and the end result will be the creation, the development of real-time retraining of patients through augmented reality games. That's the basic concept of the OActive project, and I will not expand anymore. I will leave the colleagues to present the different aspects of the OActive, and I would like to wish you to have productive training, and with that, I will pass the floor to Ioanna. Thank you.
Thank you, Kyriakos. I would like to invite Dr. Papaneophytou from University of Nicosia and Dr. Ramon Meseguer to give their presentation on biochemical modeling and inflammation biomarkers.
Good morning. My name is Christos Papaneophytou. I'm from University of Nicosia. I'm working on the determination of biomarker levels in samples from patients with osteoarthritis. Now, as Kyriakos mentioned, the aim of the project is to develop a computational hybrid model for the monitoring, the prognosis, and development of the disease. One of the most important steps when we want to develop such a model is to collect the appropriate information and data to fit the model and develop and validate the model. And this step that we call the clinical studies is challenging because it involves human subjects. And today I'm going to present our approach, how we manage to collect the data and the information. And there, Ramon, we talk about the determination and validation of the biomarkers from different samples from human subjects. Now, the overall objective of the program is to examine the relationship between the chemical biomarkers related to osteoarthritis and clinical diagnosis. And we are going to use all these results to develop a computational hybrid model in order to predict and monitor the progression of the disease. So first of all, we have to recruit and evaluate the patients. Subsequently, we have to determine the concentrations of 6 biomarkers in blood samples from patients from the 3 cohorts. And then we want also to investigate potential exosomal microbiota biomarkers and whether there is a relationship between these biomarkers and the progression of the disease. And finally, we want to develop a method to correlate and compare the concentrations of all the biomarkers with the clinical diagnosis of biomarkers. Now, why do we need the clinical studies? The aim of the clinical studies to collect the data and to examine their relationship with the development of the disease. And the clinical studies involve the collection of data and information from 3 different cohorts from Spain, Greece, and Cyprus. And the data from the 3 cohorts will be used for the development of the computational model. And then we are going to develop some other tools, for example, augmented reality tools, in order to help patients suffering from osteoarthritis. Regarding our methodology that we follow to recruit the patients, first of all, we get approval from the National Bioethics Committees from the 3 countries, Cyprus, Greece, and Spain. In addition, we prepare a questionnaire to facilitate the process and also to collect the appropriate information. Moreover, we prepare a consent form in order to explain to the individuals the aim of the project. The recruitment of the patients is being carried out by the clinicians based on the criteria established by the American College of Rheumatology. And we took some actions to facilitate the recruitment. For example, we prepare a leaflet written in simple language explaining the benefits of participating in the study. In addition, we offer a gait analysis free of charge to all volunteers. We organize a workshop in order to inform patients about the benefits that we are going to have by participating in the study. And we prepare also an email and we send it to our potential patients in order to increase the recruitment. Finally, we collect the biological samples, including blood, urine, and fecal, and we prepare some internal protocols to have a uniform way to collect and store the samples. Importantly, we make sure that the anonymity of the patient was maintained. This table here summarizes the 3 cohorts from Julafe, Spain, animals from Greece and Cyprus. So in Spain, we want to study healthy individuals in high risk of developing osteoarthritis. In Greece, we perform a post-traumatic evaluation of athletes, while in Cyprus, we study elderly patients with established osteoarthritis. And here you can see the minimum number of patients we want to recruit. In addition to the blood samples, we want to collect information regarding some socioeconomic aspects that is well known that they facilitate the progression of osteoarthritis. And finally, we want to use all this data and information to develop the hyper model. And this is an example for the data collection from Julafen in Spain. So as you can see here, in Julafen, currently we have recruited 93 patients, 62 women and 31 men. We dismissed 11 women and 4 men because they didn't fulfill the criteria for the project. That's for me. And Ramon now will continue with the second part of the presentation.
So this is Ramon Oseguer from Leitat, and I'm going to talk today on the use of biomarkers as a tool. Sorry, I have some problems with the video. Sorry. Now, as a tool for the prevention, diagnosis, and prognosis of diseases, and more specifically of osteoarthritis. Then, first, that we have to do is to define what is a biomarker. In a broad sense, a biomarker is a medical thing, not necessarily related. As I said, that there must be a biomarker, there has to be a solid scientific evidence that a biomarker consistently and accurately predicts a clinical outcome, either a benefit or harm. So then the biomarkers can be used in clinical research and practice in any of the fields, going from different diagnosis, prognosis, screening, etc. So when we look at osteoarthritis, there are many diseases or disorders that may cause the onset of osteoarthritis, thus making difficult the study and validation of the new biomarkers. These multi-causality forces then to increase the number of patients that should be included to demonstrate that a signature is really correlated with the propensity and the development of osteoarthritis. Okay. So of course, there are a number or different number of biomarkers that has been described and are here in this table, following the detailed classification or schema proposed by the National Institute of Health. Some of them are burden of disease or from prognosis predictive or diagnostic. In this project, we decided to select three of the mediators of the biomarkers that have a role in the osteoarthritis, and some others that are related to inflammatory cytokines. Knowing that for the osteoarthritis is not considered an inflammatory disease, but is implicated somehow in the progression of the disease. So, here is one example of the results obtained analyzing the plasma sample from the osteoarthritis patients in the University of Cyprus. The results obtained, here the first one, showed that the levels in plasma of the inflammatory of the inflammatory biomarker were below the limit of quantification of the ELISA, suggesting that these inflammatory cytokines are released in situ, so they are useful when we analyze the synovial liquid, but not the plasma. In contrast, it was possible to quantify the levels of the prognostic biomarkers of the bone and cartilage degradation and synthesis, but only there was a correlation between the cartilage oligomeric matrix protein, here it's shown, the cone, biomarker, and the severity of knee osteoarthritis. Thus, the restricted number of positive marker correlation in this population reinforces the need of finding new biomarkers. So that's why in osteoarthritis we decided to move to another analytical level. We will try to extract information from different sources of fluids, organs, and tissues of all the main molecules from the human body by means of the technology available. Of course, it is possible to cover, it's not possible to cover all the study, both for its size and the cost that it represents. But we can do it partially. Then, in the OActive project that we do, what we did was propose the analyze the intestinal microbiome to find any dysbiosis correlated with osteoarthritis and to study the content of microvesicles related by cells or exosomes to analyze their protein and nucleic protein. So first, I have to explain what are the exosomes. There are different ways that the cells use to communicate in a short distance and long distance. And the exosomes are one of the players in it, that they have the ability to transfer information locally or to distant tissues in the form of their content, as mRNA, some signaling proteins, enzymes, microRNAs, etc. Thus acting as signalosomes, regulating many different physiological responses as the ones shown in this list here, like cell metabolite signaling, development and regeneration, or diseases as tumor progression and metastasis or cardiovascular diseases. But there are different sizes of microvesicles. There are not only exosomes, the ones that are released from cells. The exosomes are the smallest ones from 30 to 150 nanometers. Some plasma membrane sheathing that are bigger, from 100 to 1000, and also end-death products, the apoptotic vesicles that are from 100 to 5000. So, and here is an example in urine extraction that urine has a low level of exosomes, so the methods of extraction are less stringent, let's say in this way. And you can see here that the most of the vesicles obtained are from corresponding to the exosomes, but there are some contamination from other kind of vesicles. When we go to plasma, that we see here is a more pure composition of exosomes. There is a small amount of bicycles that are not really exosomes. Okay, so then now we are working is extracting those exosomes from all the samples from the clinical studies, and then to carry out the study on protein content and microRNA. The second, the second group of biomarkers that we will include in OActive is the microbial component of the intestinal tract. In the last years, due to the possibilities of massive analysis of microbiome by new sequencing technology, it becomes clear that there is a close relation between the health status and the composition of the microbiome. Any change that we call dysbiosis will imply health disorders or diseases due maybe to environmental factor or genetic susceptibility that will affect our immune system, and then it will exacerbate the diseases as cancer, type 1 diabetes, or some other diseases. Here there are three examples of one is inflammatory bowel disease, type 2 diabetes, and necrotizing enterocolitis. That is clearly the dramatic change that is has on the go when they have at the microbiome level. As you can see, the different families that change completely for each of the diseases, and each one has its particular pattern. In osteoarthritis, that we know is that there are some commensal bacteria that infiltrate the calcifier cartilage, but not too much, too many data we are already published. In fact, there is only one paper published last year that they found a real correlation between one family of bacteria in relation to the knee osteoarthritis. They studied a large cohort, and they included 124 cases of osteoarthritis and against 870 controls. And as I say, they found an association analysis with the streptococcus with the knee joint effusion. Here is shown in this table here. But the authors stressed the need of increasing the amount of data, not only to obtain the solid biomarkers, of course, but also to understand the relationship between our intestinal microbiome and its effect on osteoarthritis, direct or indirect. So that's all from my side. So thank you very much, and we are open, of course, to any questions you want to ask us. Thank you.
Thank you, Ramon. At this point, I would like to invite my colleague, Dr. Marinela Tsakalova, to inform us on any questions that are asked through the chat. So please feel free to write down your questions, stating always your name and your affiliation. Marinela, do we have any questions?
Good morning, everyone. I don't know if you want some details about some pictures that Ramon showed earlier. Is there still any question from Konstantinos? I can see one. Konstantinos, do you have any question regarding the photographs and the images that Dr. Ramon showed earlier? Hello?
Hello, can you hear me?
Yes, can you please write down your name, your affiliation, and your question again in order to make smoother the conversation? We will present the question to the presenter.
I'm a therapist. I'm owner at the Therapy Center. I have a question. Yes, the last of the images about osteoarthritis, is it the only one that has the osteoarthritis, or the rest also have osteoarthritis? I speak about the second.
Can you please indicate your question, your name and your affiliation in the chat room? We can't hear you properly. Thank you.
Okay.
I think that by mistake, Konstantinos has left the meeting. So Let's move on to the next agenda item. And if needed, we will come back to this. Now the next agenda item is behavior modeling and environmental biomarkers. Mr. Gianluca De Toma from SmartX and Dr. Thijs Svinen from KU11 and Dr. Sotirios Tsoulis from CERT will give this presentation.
I'm Gianluca De Toma, working at SmartX. That is a small Italian company that works mainly in the field of wearable devices and textile systems. I hope that you can see well my screen. So, as I said, the presentation deals with behavioral modeling and environmental biomarkers. So, this constitutes the second input for the hypermodeling that you saw before in the other presentation. And in this presentation, we are going to show an overview of the activity, the development of the wearable system necessary for the building of the model, the approaches used for the construction of behavioral model, and then the part on the social and environmental factors and their relation with the osteoarthritis. The main scope of our activity is to detect and measure user physical, mental, and social behaviors and develop, in this case, a mathematical model for the osteoarthritis patients. The objectives are the assessment and modeling of behavior of the patients related to physical activity, as well as their social interaction and behavior, as well the development and implementation of model for mental, emotional, and social state assessment. This constitutes further input for the algorithms developed in the project for assessing risk and providing personalized diagnosis and treatments for the osteoarthritis. Going details in the activities is constituted mainly of two parts. So the first one is related to the behavioral model, and the second one is dedicated to the social determinants in relation with the osteoarthritis. As you can see, on the behavioral model, we are using the wearable system developed ad hoc for the project. We're getting data directly from the patients. Then this data will be elaborated, analyzed to create and constitute the behavioral model itself. On the other side, data will be gathered, analyzed to identify social attributes and cognitive and social determinants to complete this view on the patients. Both of these activities constitute inputs for the hypermodeling framework, as you can see before, but at the same time, an important input to build personalized intervention through augmented reality within the frame of the project. Concerning the behavioral model, the concept starts from the development of a wearable sensor to acquire data directly from the patients, as I said. In this frame, we thought to use these devices, this system, into different setups into environment, let's say. The first one is a controlled environment, a laboratory setting, let's say, and it's characterized by short session of acquisition that needs high resolution signals to monitor the movement of all the lower limbs of the patients. On the other side, we need a system that is able to monitor the patients directly during his daily activity, so mainly at home, and that would be able to recognize activity intensity, steps down, posture, if the patient is walking, sitting, this kind of activity for a very long period monitoring. We are talking about 8 hours per day for 1 week or more during the project. All these data collected in this way, of course, are gathered and analyzed to develop directly the behavior, what we call the behavioral model of the patients. Going details on the system, I neglect some technical information, but what is important, as I said before, that we developed 2 different setups. The systems are based both on inertial platform systems, so the accelerometer, gyroscope that we have in our cell phones. Let's say this first version that is necessary for the laboratory setting, the controlling environment, let's say, we have the need to control and the need to be able to use more devices at the same time. So this device is developed, the system is developed to use 6 systems in the same time and work with high sampling frequency. This means that we are going to collect, as I said before, high resolution signal. Of course, also besides the electronic, we have to take care also with the packaging part of the device. You can see the design on the right here bottom, and this is the final result of the system. Of course, we are talking about wearable systems, so what we need to do also is to develop a series of textile accessories to wear the system. At the beginning, we were thinking about some clothes where we can integrate the devices, but due to the necessity to have a quick setup to on and off different patients, then we decide to develop some accessories, some elastic bands that can easily adapt to the different sizes of people. But besides the simplicity, let's say, of these accessories, it's necessary to take in account that we have different steps of development for a wearable system. So you can see on the horizontal side, let's say, that we start for a wearability study. The sensor functionality study, it means that the system coupled, the device coupled with the textile part should work correctly. Then an integration study and the prototype study. This means that we have to select materials, model and pattern the prototype. Then we have an handcraft part, cutting the fabric and design the prototype, manufacture the prototype, then test it with an iterative loop, let's say, to change and adapt it according with the feedback that we have from the other partners. The second system, you can see, is quite similar in the package to the other version, but in this case, it's necessary for long-term monitoring and mainly at home monitoring. So the 2 differences that I want to underline is that in this case we have lower, let's say, resolution of the signal with the sampling frequency lower for 2 reasons. This because we need not only the raw signal, but we need the kind of activity classification about the intensity, the position, the steps, as I said before. And since it has to be used at home, what we need also is to extend the lifetime of the devices. This was why we use a lower frequency to sample the data. In this case, the data is available in a format, in a common format. It's the CSV format that is easily adaptable to and usable with all the analysis software available on the market. We developed also an app for the system and to achieve our scope, and the app allows us to pairing the devices, assign the placement on the body. You can see the spots, color spots here on the body, allow us to stream in real time the data, and of course to control the start and stop of recording of the system. But we provide also a kind of backup recording on an internal micro SD to avoid loss of data. We have a video here since we cannot do a face-to-face demo with only 2 devices. You can see the app that allows to connect, in this case, to system, start the registration. Selecting the device, you can have the stream of the data provided by the system. Okay, these are the data. And then disconnect the devices and verify that you have the correct file. These data are required, of course, to build the model. As I said before, the main task is to study the everyday activities in regular environments. It means at home or in any case during the daily activity of the patients. Of course, as we say, we are going to use wearable devices and use the data coming from the IMO sensor. The main question that we would like to answer, as I already said, is how often and how long a person perform a kind of activity. Practice, as mentioned, we need to recognize if the patient is sleeping, sitting, the activity, the kind of intensity of activity of the exercise that is doing. To do that, we need also a large scale monitoring, so in terms of days or weeks. As I said before, we started with 1 week. We have 2 possible approaches to build the model in this case. So the first one is the change detection method. That means we are going, as first thing, segment the input data in a series of windows, apply a deep autoencoder models to extract the representative features for the input data. The extracted features then can be used to calculate the distance between 2 consecutive windows, and where the timestamps corresponding to local maximal distance can be detected as the breakpoints of the model. The second approach instead is the characterization method, where we use Windows-based techniques, in this case the convolutional neural network combined with long short-term memory network, trained through that is being trained through a collection of lab-based experiment. That's why we also need the laboratory settings to get this information. The model is boosted from predefined segments. It means that time series segments between 2 breakpoints can only belong to 1 class, and we can apply the majority voting or an ensemble schemes to achieve higher accuracy and robustness of the model. Concluding my part, this is an example of how we can use this model. On the left, you can see the different steps of the elaboration of data. So from the raw signal, the segmentation in different windows, the processing and the classification for the model. And in the example, you can see how it can be used, for example, for a fall detection system. So the patient, in this case, is wearing a wristband. And on the bottom part, you can see that the system receives input from the pre-trained network. In this case, the client, so the host, let's say the mobile phone in this case, is able to recognize, thanks to this pre-trained model, if the condition of the patients is normal or is detecting a fall of the patients. From my part is all. I'll let the floor to Tess from the environmental section. If you have question or other, we can answer to that at the end of the presentation. Thank you very much.
Okay, I will redo my talk.
Okay.
Yeah, to discover factors that contribute to OA onset and progression. The sensors and the biomarkers we discussed this far likely contribute to more intrinsic or person-related factors. Next slide. Such as age and body composition, but do extrinsic or environmental factors also contribute to knee OA. And for that, we need to consider the people living around us, but also the built environment. Can you tap the next slide? Okay, next one. Okay, in the literature, next slide, these factors are termed contextual factors and act upon the relationship between knee OA and an outcome of interest, such as OA prevalence or pain or functioning. Next slide. To arrive at this best evidence on the impact of contextual factors in knee OA, we considered a blend of knowledge, including patients, experts, and of course the scientific literature. Next slide, please. Relevant work already exists. The World Health Organization developed in a consensus-based approach a huge taxonomy that is transdisciplinary and international and has guiding definitions on what concepts may impact on health or functioning. Next slide. Of course, this taxonomy is too big for use in research or clinical practice, and it was already tailored to general OA, but not knee OA. So what we did was further tailor this taxonomy using the major OA cohorts and expert input. Next slide, please. To come up with about 50 factors that may be relevant as environmental factors in knee OA. Next slide. And we entered these in a data-driven approach. And in the first step, we searched the literature for narrative reviews on this topic. These were quite few. And then we built upon our 50 concepts with a scoping review. And we entered these concepts in PubMed to conclude that it was useful to do a systematic review on the socioeconomic factors, but we should explore in a pilot study all the others because there was very few literature available. With, of course, the overarching aim to come up with a list of concepts that can be matched with the hypermodel of parameters in the artificial intelligence-based approach that was discussed before. Next slide, please. In the remainder of this talk, I will focus on the strategy we used for the review. Of course, we need to include the right studies. So we built criteria based on the PICOS framework. The most important thing is the comparison. So each study should include a relationship between socioeconomic factors and a key outcome, such as pain, physical activity, and activity capacity. Next slide, please. To find the right studies then that match this criteria, you need to develop a search string that should be entered in the major databases, the PubMed, Embase, Web of Science, and CINAHL were the databases of interest. And of course, this is a matter of linguistic issues. So you have to also screen the most relevant papers and use a synonym list to come up with the relevant search terms. Next slide, please. And translating the string is a little bit like coding a computer program or software. Next slide, please. That should be entered in a database as seen here. Next slide, please. When you end up with all the relevant articles, you need to rule out the duplicates and to match each study with the criteria. A very useful software package for this is Ryan, which is an open source package to filter all these studies. Next slide, please. And in the pre-final steps, you need to extract the data. So you develop a coding form including relevant information such as was there a randomization, what were the key intervention components, and so on. Next slide. Then you assess the quality and you make a decision whether the performance of a meta-analysis is useful. And you also try to tap into the studies that are eligible for doing a meta-analysis. The most used tools to judge quality or the Newcastle-Ottawa scale for non-randomized trials and the Cochrane risk of bias tool for randomized trials. Next slide, please. And as a last step, You try to catch and you summarize all the evidence that you could find in the studies by using some fancy statistics, which is most often used a random effects model. But of course, in these kind of types of studies, you end up with a lot of correlation features, so there are advanced statistics for that. In the last step, there is a writing process, and you present everything in forest plots of other graphical figures where you try to build up on the strength of evidence. So in the end, you come up with the effect of contextual factors and report this effect in your paper. So thank you for your attention, and sorry for the technical issues that were encountered.
Thank you. Apologies for this delay also. We would like now to invite Sotirios Choulis from CERT to conclude. We are a little bit short on time, but please, Sotiri, go on.
So I will just very briefly introduce myself. I'm Sotirios Choulis. I'm an assistant professor at the Department of Computer Science and Biomedical Informatics at the University of Thessaly, and recently also a researcher at CERT. I think there is some kind of misunderstanding, and some of my slides have been presenting earlier, but I will try to provide some a little bit different commenting to give some new information. So I'm going to talk about real-world activity recognition for behavioral modeling using mainstream devices. Our task here is to study everyday activities in regular environments, and in particular using devices that are easy for someone to carry around through the day, such as smartwatch, smartbands, and we tend to use collect data such as accelerometer data and gyroscope data. We do this in order to be able to answer questions such as how often and how long a person performs a specific activity, for example, rest or exercise, or even further, how long does it take to perform a transitional activity, for example, someone who is currently sitting and trying to stand up. In practice, to do this, we need large-scale activity tracking. I will give some more information about the data that we have at hand at the end if there is time. The problem is that most activity tracking experiments are very limited and usually performed within a lab. So we have a good reason to believe that labeled datasets usually are small and far from realistic. I believe, for example, you should know that the people who usually perform these activities and label the data belong to specific groups, for example, undergraduate students. So there is an urgent need for accurate tracking with wider generalization in large-scale data. The core idea of our method is to use unsupervised learning for time series segmentation, and we intend to achieve wider generalization, for example, taking advantage of huge collections of unlabeled data. The problem here is that the traditional change point detection methods are not making it easy to detect such breakpoints. And that is because most of them rely on a prior parametric model of the time series data, and they also very usually utilize simple feature extraction from the input data, such as the mean, the variance, etc. Now, one possible solution that we propose is to utilize a deep auto-encoder model to extract the most representative features in the time series data. I will just give a few points of how this method works in general. First, we segment the input data into a series of windows, and then we apply a deep auto-encoder model to extract the most representative features for the input data. Then the extracted features can be utilized to calculate the distance between consecutive windows. So finally, the timestamps corresponding to local maxima distance can be detected as the most likely breakpoints. The subsequent step would be to perform a typical classification for activity recognition using window-based technique. We already have some experience on using these techniques, and we know that they're relatively successful. And in order to train these models, we're still going to use lab-based annotated experiments, but we expect that we will boost significantly their performance by using these already retrieved predefined segments. For example, we expect that the time series segment between two breakpoints can only belong to one class. So if we take this as granted, we can subsequently apply, for example, majority voting or ensemble sims to increase accuracy and robustness. Finally, I would just like to give some information about the dataset that I have been working on lately. These are data collecting using a Samsung Gear smartwatch, and they are partially labeled by users with kind of activities like sleeping, sitting, low intensity, moderate intensity exercise, and hard works. So they're not fully labeled, let's say, in all the aspects that we would like to see. And we have been recording linear acceleration, angular velocity, and heart rate. And this data has either been collected in the scale of days or weeks or months. So we certainly lie in the big data scenario. So that's all on my behalf. Thank you very much.
Joanna, for this part of the agenda, not yet. If you have any questions, please write it on the chat, please.
Do we have a question for the previous item?
Just give me 1 second. Okay, so we have one question from Konstantinos that he's a physiotherapist. I think it was at the presentation that Ramon presented. So Ramon, can you please inform us about this question? I think that it was regarding a slide that contained a picture of osteoarthritis pathology. Can you please answer to this?
Example showing the KNL scores.
Okay, which one? Because
I will stop sharing, and yes.
Okay, can you see my screen?
Yeah.
yes.
Thank you.
Okay,
Yes.
I think that Konstantinos is probably referring to this slide, and particularly in this figure here. Here we have an example. We have an example of the KNL scores. KNL score actually is a method of classifying the severity of the osteoarthritis. We have actually five grades. So, and if Konstantinos needs more, let's say, details regarding the KNL scores, I can send to him the paper that we obtained this figure. Okay, so all of them are images, real images from patients suffering from osteoarthritis, but the severity of the disease is different. So here we have grade 1, grade 2, grade 3, and grade 4.
Okay.
And I don't know where Konstantinos can hear us.
Okay. Yes, thank you. I think that this replies to
Konstantinos. Okay,
comments.
Konstantinos just replied that he can hear us, and it's okay. Okay, thank you.
All right. Thank you, Christos. And
Joanna, we have one more question from Mariam Lamhari. Sorry if I'm not pronouncing the name right. So is this regarding to the second presentation, Mariam? Yes.
Yes, it is. Can we see? Can you share your screen, Marinella, so that they can?
Just give me a second.
Or you want to read it?
Okay.
It refers to the slide that we just saw. So it's for the first presentation again.
Are you able now to see?
Yeah.
Okay, so this is regarding the second part of the presentation. So I don't know if somebody from the presenters want to answer.
Christos, Ramon, can you see the question? I think that.
Yes, Joanna, I can see the question. So I think I'm going to share my screen again.
Okay.
Okay, in order to communicate better.
This has to be the last question, though, because we are short on time. And
okay,
share the screen and please reply to this.
Okay. This is on this work was on by Christos. So if you want to answer, I answer myself.
No, Ramon, I can answer if you want. So the question is about the the inflammatory biomarkers. This is just the data from our cohort from Cyprus. In Cyprus, we are dealing with patients with established osteoarthritis, and as expected, the profile of these patients is different compared to patients with the onset of the disease. Okay, so these results are normal because according to the literature, the levels of the inflammatory biomarkers are low because we are talking about the established osteoarthritis. So the level of these biomarkers are elevated on the onset of the disease. And I don't know whether this answers the question.
Can we see in the comments, are you okay with this answer?
Mariam?
Mariam?
Oh, yes, thank you. Just a last point, Joanna, this is very common not only in osteoarthritis, in other types of arthritis as well. So we have more or less the same profile in rheumatoid arthritis.
Okay.
Okay, thank you.
Thank you. Let's now move to the last agenda item for the session. Let me share my screen. This is the presentation for the biomechanical modeling of the knee presented by Dr. David Bridgman from Liverpool John Moores University.
Okay, so just to introduce myself quickly first. My name is David Bridgman. I'm a postdoctoral research associate at Liverpool John Moores University in the School of Sports Science. My background's on biomechanical modeling and in particular osteoarthritis. And today I'm going to talk about biomechanical modeling of the knee and in particular how it relates to the OActive project. So in terms of a brief outline, I'm going to first talk about, give a brief introduction to what we mean by biomechanics and how it relates to knee osteoarthritis. I'm going to go on to talk about some of the biomechanical models we're using in the OActive project and go over a basic pipeline. And then I'm going to talk in more detail about some musculoskeletal models we're using, some finite element models, and then conclude and give some closing remarks. But to start with, I thought it'd be useful to go over what we mean by biomechanics. And I think a good definition is that biomechanics is the study of the mechanical laws relating to the movement or structure of living organisms. And the key words here are mechanical, movement, and structure. What we're really trying to do is take a given motion or movement related to something we know about the underlying structure or anatomy of the subject and try to predict some idea of what the mechanics are that are going on, whether that's in terms of the forces or the angles or the moments. We can do this on different scales. We can look at the body scale, where we might look at joint angles, external loads, and external moments. These are generally things that we can measure directly. We can go a step further and look at the internal joint scale, start looking at the loading going on inside the joint itself, the joint moments, and also the forces going through the individual muscle elements. And then we can go a step further again and start looking at the tissue scale and look at the stresses going on through the soft tissue elements in the joint. Now, as we go down through these scales, we increase significantly in complexity. So on the body scale, for instance, these are things we can normally easily measure, whereas on a joint and tissue scale, these are metrics that are hard to measure directly, and we rely on some kind of modeling in order to predict them. We also possibly increase clinical relevance, particularly when we're talking about something like osteoarthritis. What we're really interested in is the stresses that are going through the tissues themselves, instead of necessarily the way the person's moving in terms of their joint angles. In terms of biomechanics and knee osteoarthritis, we know that biomechanical knee instability can lead to abnormal biomechanics and cartilage degradation. This can disrupt biomechanical signaling inside the joint and lead to cartilage matrix degradation. And the important thing here is that this is not a one-way process. This is actually a forward feedback loop. So this cartilage matrix degradation and cartilage degradation can actually lead to further biomechanical knee instability. So biomechanics is important not only in understanding how the disease initiates, but also how it progresses. So this slide shows a basic pipeline we're using in the OActive project to generate some biomechanical parameters about the subjects we're looking at. At this stage, it's not necessarily important you understand exactly what's going on in this slide, but just the general principle. So we have some input data coming from our patients. In our case, this is from motion capture trials and also some anatomical studies, normally from MRI. And then we have two separate pipelines we use that are linked. We have a musculoskeletal pipeline, which carries out our joint level analysis. So this gives us information about the way the joint is being loaded. And then we have our finite element pipeline, which is a tissue level analysis, which gives us more of an understanding about the stresses going through the soft tissue elements themselves, like the cartilage and menisci. And I'm going to go through both of these pipelines in this presentation, so hopefully it'll make more sense at the end. So in terms of the musculoskeletal modeling, we're mainly using a tool called OpenStim. So this is a freely available open source software that allows you to develop models of the musculoskeletal system. It's capable of modeling skeletal structures, joints, and soft tissue elements. It's user extensible, so you can add new components and functionality through scripting or coding. And the good thing about it is a large community support base. So if you do run into any problems, it's often easy to get really good feedback and support. And I'll put a link down the bottom if anyone wants to sort of look it up and find more details. In terms of the input data from the musculoskeletal model, mainly it's from motion capture trials. So by this we mean we have markers placed on the skin of a subject, in this case the lower limb, and we track these in 3 dimensions using cameras. So on the left you can see an example of a subject where they have markers placed on relative locations on the lower limb. And on the right you can see 2 types of trial that we're using, where you can see those markers represented in 3 dimensions. So we have static trials where we have the subject stand still, and we use this for scaling. And then we have dynamic trials where we get the subject to move in a given way in order to understand what's going on during that motion. So the first thing we need to do is build the model. And the good thing is we don't have to do this from scratch. We can take a generic model of the lower limb anatomy, which in this case is derived from cadaveric studies, and it already contains the body, muscles, joints, and other soft tissue elements that we're interested in modeling. And then what we need to do is scale this generic model so that it best matches the subject that we're looking at. And in this way, we can develop more subject-specific modeling tools. So you can see here on the left an example of a generic model with the location of markers attached to it. In the middle, you can see a marker cloud of points from a static trial on one of our subjects. So these are those marker locations in 3 dimensions when the subject's standing still. And what we try to do is best map that marker cloud of points from our static trial onto our generic model and scale that model appropriately. So on the right, you can see an example of a model that's been scaled using that marker cloud 3-dimensional data in the middle. So we go from a generic model to a scaled subject-specific model. We can then start to look at gaining some information about the way the subject's moving in dynamic trials. So on the left, you should be able to see a video of the marker cloud again during a dynamic trial moving in 3 dimensions. And what we can do again, similarly to scaling, is we can now map these 3-dimensional marker points onto the subject-specific model that we just created. In that way, we can create a fully articulating skeletal model of motion. And this enables us to get information about the way the subject is moving. We can get kinematic measures like joint angles, etc. And this is a process called inverse kinematics. And again, I'll put details down the bottom of these slides if anyone's interested in more information. So we can take this a step further and start looking at some joint scale analyses, looking at the muscle and joint force calculations. And for this, generally, we're interested in the loading part of the movement. So I've got a video here just showing the part of the movement where the loading is taking place. So you can see the subject moving again, and the green arrow is the ground reaction force. It's a load the subject is applying to the ground, and the reaction force is going up through the foot. Now, to understand how the joint is being loaded, we need to take into account not only how the skeleton is moving, but how the muscles are articulating as well. We can add our muscular elements to the model, and these are shown here in blue. And then we can do some analyses called static optimization, which allow us to calculate how these muscles are being activated during the motion. And via this, we can predict the forces going on inside the joint. When we do this, we can get a variety of different outputs. This is just an example. So we're looking at the joint reaction force in the knee, flexion moment, and the soleus force, which is an individual muscle. And this is displayed for walking, but we also have stepping trials for the OActive subjects, and also sit-to-stand trials as well. So we can look at the way the joint's loaded in different kinds of motion which might tell us something about the way the disease is progressing. So I'm now going to talk a little bit about the finite element model, which is the second part of the pipeline, if you remember. And for this, we've been using a tool called FEBio, which again is an open source software for finite element analysis. It's capable of calculating stresses on complex structures that are undergoing motion, and it is commonly used for biological structures. It allows a wide range of material properties to be assigned to different model components, like the hard tissue such as the bone, the soft tissue such as the menisci and cartilage in this case. It has some really useful companion software to allow you to set up the simulations and view their output using a convenient graphical user interface. And again, it has a large community support base, which is really helpful. Also using a tool called MITK, which again is open source, and this is capable of interactively creating finite element models from medical images. So this allows us to go from those MRI images to a three-dimensional model of the joint or whatever you're looking at. It has tools for both automatic and manual segmentation. It has tools for creating three-dimensional mesh geometries. And again, it's user extensible, and there are plugins available to extend the functionality and add new features. So in terms of the inputs to the finite element model, we're using some of the outputs that we got from our musculoskeletal model. So in this case, we're using our joint contact force or our internal knee joint loading, as well as some information about how the joint is moving. So in this case, the knee flexion angle. And we're combining this with information about the anatomy of the subject. So this is coming from an MRI. So the first thing we need to do, like with the musculoskeletal model, is create our model. And in this case, instead of the whole lower limb, we're looking specifically at the knee joint itself. So we're trying to create a three-dimensional model of the knee that we can apply those musculoskeletal loads to. So on the left, you can see segmentation of the different structures within the knee. So we have the femur, the tibia, and femoral and tibial cartilage. We'd also have the menisci as well. In the middle, you can see a surface representation of those two-dimensional segmentations, which have been smoothed. And then on the right, you can see a three-dimensional mesh of that two-dimensional surface. We now have a fully three-dimensional filled-in mesh of all of the substances that we're looking at. And this includes the femur, the tibia, the menisci on the femur and tibia, and also the cartilage. But just by looking at these three-dimensional models, we can start to see some interesting things. So here we're looking at a healthy and a severely osteoarthritic subject. And what's interesting, I think, is that you can use these tools to visualize things that you would see in the MRI. So, for example, here we're looking at osteophyte formation on the femur of the osteoarthritic subject. And these are things that you can see in the MRI, but it's really nice to be able to visualize them in 3 dimensions and rotate the model, etc., and see how these things are affecting the 3D geometry during motion. Once we've got our 3D model, we need to work on applying some kind of realistic loading to it. And this is where the outputs from our musculoskeletal model come in. So we need to define our loading parameters, how the joint's being loaded. So we take these from our joint contact or joint reaction forces in the knee. We need some information about how the joint is moving, so our kinematic parameters. And this is generally our joint flexion angles, again from the musculoskeletal modeling. We need to define some material properties for each of the elements of the model. And we also need to define how the model elements interact with each other by defining their contact properties. And this includes things like the coefficient of friction for the cartilage, etc. Once we've got our 3-dimensional model created and we've set up our loading conditions and environment, we can start to run simulations looking at stress patterns on the cartilage and menisci. So this is an example of one of those simulations viewed from the top. So this is a view of the top of the tibial cartilage viewed through the top of the femur. So the femur is transparent here. And you can see how the stress patterns are evolving on the tibial cartilage during the motion. And we can extract images like this for different kinds of subjects. So here we're visualizing this cartilage stress. So we have views for the femur and tibia for healthy early osteoarthritic and more late osteoarthritis subjects, with the lateral side of the knee on the left and the medial side on the right. And you can see how these stress patterns evolve over time in these 3 subjects. So for the healthy subjects, we have a lot of loading on the menisci, less loading on the cartilage, particularly on the medial side. Once you move into early OA, the subjects loading moves away from the menisci and onto the cartilage, again, particularly on the medial side. And this is exacerbated further with the late OA subjects. So this is a really useful tool to give us an idea of what's going on inside the joint itself and the actual stresses that are being caused to the soft tissue elements. So just to conclude, in summary, we've shown how multi-scale models can help us to understand the effect of degenerative disease on joint tissues. We've shown how it can be developed using open source software that's freely available and easy to use. And we've shown how they play an important role in OActive to provide information about knee joint loading to the neural network and other computational elements that you'll hear about later on. So in terms of future work, we're looking at validating these models on instrumented data sets, carrying out a full analysis of data collected from the complete OActive cohort, some of which are still coming in, and then looking at possibly using the results to inform bioreactor experiments, investigating the effect of these cartilage stresses on real life in vivo tissue, or in vitro, sorry. And this completes a circle from macro to micro scale. So I'd like to thank you all for listening, and if you have any questions, then feel free to ask. Yeah, so I think in an ideal world, you'd want to use subject-specific geometries for both the OpenSim model and the FE simulations. That's not always that simple to do. The OpenSim doesn't necessarily have great tools in order for you to import those subject-specific simulations, although I know they do exist, and you have things like the map client, which can be useful. But yeah, obviously it's going to have an effect. I mean, I would suggest that, you know, if we're looking at differences between, you know, significantly different clinical groups, like those with late OA and those that are healthy, the differences in loading that you see using a generic model are likely to be similar to those you would see using the subject-specific model for the OpenSim. So although it will make a difference, I couldn't say whether it'll be a sort of clinically significant difference when you're talking about substantially different clinical groups. When you talk about simulating knee flexion, yeah, I think simulating the other degree of freedoms would affect some of the FE results, but they also make the FE model much more complex to run and reduce the ability for it to run effectively. So we found that applying flexion and restraining the other degrees of motion, I mean, we do have passive abduction and adduction of the joint. We do allow it to settle into a passive abduction. But I think we would need to start modeling some of the restrictive elements in the joint, such as the ligaments, etc., in order to allow that full degree of freedom. So it's a more complex model. It's something we're working on, but I think, yeah, in an ideal world, it would be useful, but I think we can still get, you know, sort of good and representative results from the simple models that we're using.
Hey, David, there is a second question. Just give me a second to share my screen. Here you are. Can you see my screen now?
Yep. Let me see.
It's about the type of model of the model that you use.
Is it the constitutive model for the soft tissue?
Mm-hmm.
So we're using an Ogden model for the cartilage. I couldn't go into much more detail about that. I'm not an expert on finite element modeling. We have other users here at LJMU who are more experienced and have been developing some of these models. But if you want more information, I can find out for you and provide it at a later date. Yeah, so so you're asking about the material properties and how we derive them. The material properties are estimated from literature studies, so they're not anything that's particularly subject-specific. In theory, you could have more subject-specific material properties for the bone. You could look at the sort of grayscale techniques for extrapolating material properties, but the quality of the MRIs that we're working for are prohibitive to doing anything more complex. So at the moment, they're just generic material properties from the literature.
Okay, thank you. So now we will move to a very short break. We will have a 10 minutes break, but before we leave, I just want to remind you not to log out during the break in order to be back on time for the second part. So let's meet again at 11:20. Okay. Thank you all. See you in 10 minutes. Hello again. Let's start the second session. For those that have just joined, I'm Ioana Katsavou from Axie Innovation. And before we start, I would like once more to highlight some organizational points very briefly. You all know that the session is being recorded. All training material will be available at oactive.eu. Please unmute your microphones and switch off your cameras. You can ask questions through the chat. Please, you have to state your name and your affiliation when posing a question. And then presenters, after their presentation, will reply to your questions. And at the end of the session, we will have an evaluation through the Slido application. You can see, you can join at the end of the presentation slido.com and use this password. So I would like to invite Dr. Dimitris Tsopoulos from CERT to present the computational modeling empowered by big data and deep learning. Professor Paulo Lisboa from Liverpool John Moores University and Mr. Christos Kokotis from CERT will also present in this session.
Hi to all. Briefly to introduce myself, so I'm Dimitris Tsopoulos. I'm a senior researcher in biomechanics at CERT. I'm working with the team from Liverpool John Moores University on the biomechanical modeling and the building of the machine learning models for the OActive. So I'm going to make a short introduction related about our tasks and how we're going to implement. And then Professor Paulo Lisboa and Mr. Christos Kokotis are going to talk with more details related to the implementation of the project. So please go to the next slide. Yes, as I said, I'm going to present related to the framework that we're trying to build related to the big data analytics for the prediction, the diagnosis of knee osteoarthritis. So next slide. So as has been mentioned, osteoarthritis is not easy to predict or treat, and nowadays biomedical research and clinical practices on knee osteoarthritis are struggling to cope with the growing complexity of interactions, with again knowledge being fragmented and associated either with molecular process or with tissue and organ phenotype changes related to clinical symptoms. All these data that characterize knee osteoarthritis are high-dimensional and heterogeneous. So with next slide. So with the OActive project, we're trying to make a significant leap forward, adopting a multi-scale holistic analysis where patient-specific information from various levels, such as molecular, cell, tissues, and whole body models similar to those that David presented earlier. We're trying to integrate and combine all these informations from other sources, like environmental, behavioral, and social risk factors, similar to those that are presented also from Gianluca Fez and Sotiris, to build model predictors for new personalized interventions and trying to delay the onset or maybe slowing down the progression of osteoarthritis. In general, OActive targets at patient-specific predictions and intervention by using combination of mechanistic computational models, simulations, and big data analytics. As you can see on this slide, is how heterogeneous data are related to the knee osteoarthritis and how complex is the problem to predict this disease. So to achieve our aim, Ioana, next slide, please. We have started to develop a hypermodeling framework, we can say, or big data framework for OActive, which include data management mechanism to ensure a high level of data quality and accessibility for the big data analytics applications. Development of data processing algorithms to improve data quality and consequently facilitate the efficiency of the data mining task. And also developing data mining techniques to extract knowledge. And finally, at the end, our last target is to design and implement personalized predictive models. But for our aims to build all this model, the main thing that we need is our data. We need a lot of data. So for this reason, Ioanna, please, the next slide. So for this reason, we are for the training of our models, firstly, we use the Osteoarthritis Initiative, which is a multi-center prospective observational study of osteoarthritis. This database has established and maintained a history database of osteoarthritis patients for around 5,000 patients between the age of 45 and 79. That includes clinical evaluation data, radiological data, and MRI data and biospecimen data. And for the validation part of our study, that also for the Osteoarthritis Initiative training models, Christos is going to talk later. But for our validation study, where during the OActive project, we are capturing data in 3 different clinical centers in Spain, Lafayette, Animus, Greece, and the University of Nicosia in Cyprus. So we have around 300 patients that have been recruited and captured and recorded various data from around 300 patients. So at the next, Paul is going to present how implement these advanced techniques for classify or try to diagnose the osteoarthritis in our data that have been captured in our labs. And next, Chris is going to talk how we use the data from the Osteoarthritis Initiative. So I think now Paulo can talk for the rest. So
my name is Paulo Lisboa. I'm in the Department of Applied Mathematics at Liverpool John Moores University. As Dmitry said, we're going to be focusing on one particular aspect, which is trying to get knowledge or insights about factors that relate to onset of osteoarthritis. Later on, we'll look at progression, but for the purpose of this talk, we look at onset. And the second thing we want to look at is to see if we can elucidate this very elusive relationship between radiological indicators of knee osteoarthritis, such as KL, the KL score, and pain. The two seem to be totally unrelated in patients, or at least almost completely so, and we'll want us to look deeper into that. And we're going to start with the baseline cohort, who presents at the first clinical meeting, looking at clinical indicators and questionnaire responses that are available at that point in time, to differentiate those patients who present with KL score, radiological score, 2 and above, from those who have 0 or 1. Essentially, real knee osteoarthritis or not. The extent to which we can do the correlation, which you might say predict the onset, is indicated in these areas under the curve, about 0.7 to 0.76, which are reasonable. You'll notice that the indications here are 2 classical models. I'll say something about a more advanced model later, but one is a tree cart and the other one is logistic regression. I'll explain in a moment, or towards the end of the presentation, why they are appropriate. So the next slide, please. Okay, so if you look at the tree structure, this presents something that's very interpretable for the clinician. It does start with an indication of whether the person has pain or not. And as you can see, the proportion indicated in green on the right of people who have advanced knee osteoarthritis would come from this very simple question. Among the cohort recruited for the osteoarthritis initiative, which comprised for this purpose just over 3,000 subjects, where the covariates stored in the osteoarthritis initiative are common to those in OActive. But the indicators, apart from knee pain, then go on to body mass index, age, knee swelling, back to age, and on to BMI again. You can see how the people go down the tree. In green on the right, you have people who are likely to have to be presenting with KL scores 2 and above, and in blue on the left, KL 0 or 1. Now, trees are relatively limited, so we wanted to look at an alternative way to present information to clinicians in a way that this risk model can be better interpreted. So we can go on to the next slide, and we looked at logistic regression, and we can present the results of logistic regression using what's called a nomogram. Now, in many areas of medicine, this is commonly used, and it's got some significant advantages over other methods, because not only does it give you a relatively accurate estimate of risk of KL2 or above, but importantly, it gives an indication of what component elements are most significant in arriving at that score for each individual patient. So the example here is a patient whose variables are indicated by the red dots. So the knee stiffness is indicated by a red dot on that score. The same thing for difficulty in going upstairs, knee swelling. The next variable is called knee pain limiting action in the past 30 days, which is high, gender, the baseline symptoms, BMI, and age. Okay, all of those red dots then map onto the scale at the top, just vertically. If you then add those numbers together, you get a total that is registered in the second from bottom line, and that maps into an odds ratio for the likelihood of presenting with KL2+. So two things you can see from here. For this individual patient, it's baseline symptoms that has the highest score, followed by age. These are things that perhaps the patient cannot change, but if you look at the size of the scales, it tells you that the other important thing that a person can try and change is their body mass index. So this provides some feedback to the clinician and back to the patient about what are the things that the patient might be able to do in order to stave off the onset of knee osteoarthritis. So moving on to the next slide. Right, if we now look at the relationship between pain in the WOMAC score at the bottom, where a higher score signifies more pain, and the KL score, which is the radiological score, there seems to be almost completely no correlation at all. If you just click one more time, please, Ioana. Right, what you can now see is that if instead of using the KL score, the radiological score, you use the inference made from logistic regression, this is the log odds, i.e. the beta x, then what you see is that there is an apparent correlation. You see at the bottom left, patients who have no KL score 0-1 and don't indicate significant pain, and on the top right, those who have both, and fewer patients are on the off diagonals, they are the outliers. We can progress from this to try and get a greater insight into what is it that differentiates the patients in these four quadrants. But the point to be made here is that the mathematical modeling has looked in through the noise of the radiological indicators and provided some insight into a correlation that was previously thought not to exist. Now, the next slide, please, is the final slide. This is a new model that's yet to be published. It's published on archives, called the Partial Response Network. It's a neural network structured as a general additive model. And what this means is that you have like logistic regression, but instead of having linear dependence on the variables, you have nonlinear flexible functions, which are subneural networks, acting on each individual function, and in fact on bivariate combinations of functions. We've applied that to this model, and what this shows is that the relationships with the continuous variables in the top two figures is surprisingly linear, and that explains why logistic regression works so well and is sufficient for this data set. The histogram is the population. The red and black lines are the estimated dependence without any restrictions. So this can be completely nonlinear. And in the bottom two pictures, you can see the same thing for discrete variables. So we have a continuous function, but it's only inferred at the two discrete points, just to show that these figures, they can actually be significantly nonlinear, but it does show why it is that logistic regression is good enough for this data set. As I said earlier, rather, we're now going to look at progression using survival models. That is, progression from people who present with KL01, progressing on to KL2 or above during the progression of the OAI study. Now, we tried to validate these models with the OActive data. What we found was that although we can pick up 160 patients, 159 to be precise, who have these covariates, all of them are recruited in a study on healthy patients who are at risk of developing osteoarthritis. So essentially, 90+% of them have KL01. So we haven't got enough variation in the target variable to provide a reasonable validation of these risk models. But we do believe that they will translate very well to external validation in other data sets. Okay, I'll take questions at the end of the presentation, but now I'd like to pass back to Dimitrios.
Hello, my name is Christos Kokotis and I am a PhD student at CERT. I am working on the development of prediction models with machine learning. We work on prediction task with classification. At this point, first of all, I would like to mention why we use machine learning models. They can explore massive design spaces to identify correlations. They can develop new individual treatments. They can predict system dynamics to identify causality and can provide improved clinical decision tools. The next slide, please. For OActive's project, we obtained the data from the Osteoarthritis Initiative for the baseline, for the visit at 12 months, and from the visit at 24 months. The data come from heterogeneous sources like questionnaire, self-reported data, and physical exams. We edited them and worked on 5 data sets. The first of them contains data from baseline, the second from the progress of the visit at 12 months with respect to baseline, the third contains data from the visit at 24 months with respect to baseline, the third contains the fourth includes data from baseline plus the data from the progress of the first visit. And finally, the fifth includes data from the baseline plus the data from the progress from 24 months. This data require pre-processing steps. For the handling of the missing values, we ideally deleted as many columns as have more than 20% of missing values. And then we tested 2 imputation strategies, K nearest neighbor and most frequent values, mode strategy. Due to the existence of continuous and categorical variables. Our study was based on Kellgren and Lawrence KL grade as outcome for the prediction. In each approach, 2 classes of participants were created. We wanted balanced data, so the majority class was reduced in order to have the same number as the minority. For example, the approach with the baseline data in the first class had subjects without knee osteoarthritis, and then the second class had subjects with knee osteoarthritis after 12 months. Each approach has different grouping for the prediction. Standardization of a dataset is a common requirement for many ML estimators. In our work, data were normalized from 0 to 1 to build a common basis for the feature selection methodology that follows. Joanna, next slide, please. To avoid bias, features are selected on the basis of 6 feature selection techniques. The filter methods include Pearson correlation and chi-square. The wrapper includes recursive feature elimination based on logistic regression. And embedded techniques include logistic regression with L1 penalty, random forest, and light GPM. The feature ranking was decided on the basis of a majority vote sum. For example, we present the feature of the baseline and plus the data from the progress of the first visit at 12 months with respect to baseline. At this point, I would like to mention that the feature selection selects a subset of relevant features, variables, predictors, for using model construction and to improve prediction performance. To rank features in terms of their impact on the final machine learning output and to build a mini explainer for a single row prediction, we need other tools like SAP and LIME. SAP is a game theoretic approach. This table gives a short description of the first 10 selected features along the associated votes that were assigned to each one. The categories of the selected features include anthropometrics, symptoms, medical history, nutrition, and all. Joanna, please, the next. Various ML models were evaluated for their suitability in the task of neosteroids prediction. They are logistic regression, k-nearest neighbor, support vector machines, naive Bayes, decision trees, random forest, and XGBoost. Hyperparameters were implemented to optimize the performance of our models and to avoid overfitting and the bias error. A 70-30 random data split was applied to generate the training testing subsets. The figure depicts the testing performance of the competing machine learning models with respect to the number of selected features for the approach with the data from baseline plus the data from the progress of 12 months with respect to baseline. The best accuracy score, 74.69%, is achieved by the combination of support vector machines classifier, and 60 features. The confusion matrix used to describe the performance of the classification model on this set. The next slide, please. In this project, we prefer machine learning models due to the small amount of data and because that the machine learning models are more understandable. The deep learning approach can provide to us transfer learning from the pre-trained conventional neural networks. Both of them in this problem need the pre-processing steps. We will use the deep learning approach for a new task. The next slide, please. Joanna, thanks. In this work, we have two classes with progression subject and no progression, and we will construct images. We will create images with the selected features and use pre-trained conventional neural networks for the classification problem. And new tools, and we will develop new tools. We will see the performance in new session. The next slide, please. Summarizing, data pre-processing steps play a key role. To avoid bias, a robust feature selection methodology was implemented. Artificial intelligence techniques with less complexity are more effective for the certain problem. And stay tuned because new tools for diagnosis and prediction of knee osteoarthritis are coming. Thank you very much.
Thank you very much. I would like to ask my colleague Marinella Tsakalova to inform us if we have any questions.
Joanna, by far we don't have any questions.
Okay. Thank you. So we can move to the next agenda item. Now, Dr. Roberto Di Gesù will give his presentation on using artificial tissues as test bench for rehabilitation against osteoarthritis.
Yes, good morning. Can you hear me?
Yes, very well.
Okay, let me a couple of seconds to share my screen. I'm Roberto Di Gesù. I'm working as a postdoc researcher for REMED Foundation, and in the context of the OActive project, whose aim was already described from other people, from Kyriakos and from other scientists. And today I will briefly show you how native and artificial tissue can be employed as highly realistic model to study the efficacy of rehabilitative movement toward the osteoarthritis, with a focus on the contribution of REMED Foundation to the OActive project. But briefly, what osteoarthritis is? Osteoarthritis is a disease involving mainly joint, most frequently hip and knee joint, and is usually triggered from several undernet pathologies as synovitis, tendinopathy, menisci damage, trauma, or something like that. And all these pathologies promote the production of pro-inflammatory molecules that are responsible for cartilage and bone damage. To date, any treatment is still available, and all resolutive approach is a total joint replacement surgery, which is resolutive, but at the same time, there are a lot of problems linked to this procedure. The main problem is that the prosthesis lifetime is limited only to 10 years at the maximum, and there is a long recovery time associated with this surgery. And the main problem is that the surgery is very invasive. So to be honest, I can affirm that for sure the surgery is funny just for the surgeon and for sure not for the patient. So in this complex scenario, what OActive can do? We can help to develop an advanced rehabilitative approach built around the patient's physiology, with the main scope to delay or reverse the clinical course of the osteoarthritis. How we can do that? OActive take advantage from interdisciplinary expertise of OActive partnership, and clinicians collect patient informations, and these information are elaborated by engineer and computer scientists using artificial intelligence. Then this interaction is completed by interaction with physiotherapists, which is fundamental to develop personalized rehabilitative movement. And in this framework, the role of REMED Foundation is to study the effect of this personalized rehabilitation, studying the response at cellular and tissue level. And in particular, the main goal is to develop in vitro model as test bench for rehabilitative movement. More in detail, our work is based on three main questions. The first one is how does osteoarthritis look in vitro? To understand that, we studied to define the parameters that can characterize osteoarthritis in vitro, both at tissue and cellular level. The second question is, what is the best way to model osteoarthritis in vitro? To understand this point, we developed osteochondral model using a tissue engineering approach. And the third question is what does the rehabilitation do to cell and tissue? To do that, we are developing a model that I will show later to apply control and mechanical stimuli to osteoarthritis model. But at this point, let me go to go a little bit deeply inside each question. So osteoarthritis is a disease that is interested both cartilage and bone. Usually, this is the image on an osteoarthritis tissue, where it is possible to distinguish an highly damaged area in which there are evident tissue damage and scar tissue, and a healthy area. We call this healthy area microscopically healthy area, in which there are no visible tissue damage. So to investigate the parameters that characterize osteoarthritis in vitro, we harvested the little units that we called osteochondral plugs, because they include both bone and cartilage together. So we harvested osteochondral plugs from damaged and from macroscopically healthy area. Such plugs were cultured using an advanced dynamic culturing system, which is a system patented from REMED in collaboration with University of Pittsburgh, and briefly composed of two-chamber bioreactor, one upper chamber and a lower chamber, which allow to feed different culturing media separately. And inside this bioreactor, it's possible to put tissue or scaffolds or whatever, and it's possible to culture in dynamic way, collecting the media that we use. This culturing approach is very interesting because allows to maintain tissue viable for several days and allows to deeply investigate both the morphology of the tissue by performing histochemistry analysis, or also to analyze gene expression, or to study the production, or in this case, the production of pro-inflammatory molecules. So this is a good approach, but there are two main issues linked to this approach. The first one is that we have a shortage of healthy tissue, which is a little portion of the tissue that we have. We usually work with surgery waste, so there is a shortage of healthy tissue. And moreover, this tissue is not a really healthy tissue because it comes from damaged joint. So we are talking about a macroscopically healthy tissue, but it's not a completely healthy tissue. To address these issues, we developed an engineered construct which is able to mimic the characteristic of native osteochondral plugs. In particular, is a biphasic scaffold composed of two different materials, which mime both cartilage on the top and bone on the bottom of the scaffold. And the main positive aspect of this approach is that we can have a big number of plugs, because we can produce a lot of plugs, and which means that we can have a high number of experimental replicates. And most important, we can work with a really healthy tissue. At this point, using an engineering model where we are answering to the second question that I showed you before, what we can use to model osteoarthritis in vitro. But how is made our scaffold, our biphasic scaffold? This scaffold is realized separately, realizing a cartilage-like component, which is based on an hydrogel, and a bone-like component on the bottom, which is composed of a 3D printed biocompatible material. Both components are cellularized using adult mesenchymal stem cells. At this point, two constructs are then assembled and cultured within our bioreactor in dynamic way, which allow to promote the selective differentiation in both compartments. So at the end of the experiment, we will have a biphasic scaffold with engineered cartilage on the top and an engineered bone on the bottom. But how we can realize an osteoarthritic model in vitro starting from an engineered construct? We used different pro-inflammatory molecules, but the best one seems to be the interleukin-1 beta, which is able to induce several responses at cellular level. And we were able to develop an osteoarthritic model, an engineered osteoarthritic model. So at this point, we used the same experimental approach that I described before, and we investigated on the engineered construct. We studied the morphology, as in this case, the gene expression, and as well the production of pro-inflammatory molecules. So now, at this point, we have both native osteochondral plugs and artificial osteochondral model able to mimic the characteristic of the native tissue. But how we can test really the rehabilitative movement effect on this model? So to do that, we are developing an experimental model in which we plan to apply the same mechanical stimuli that are employed during rehabilitation movements over both native and engineered constructs, osteoarthritic constructs. And we expect that this approach will give us information over the effect at cellular and tissue level of the personalized rehabilitation movement developed during the project. So in conclusion, we can affirm that rehabilitation can be used to delay osteoarthritis and progression. Also, an in vitro system, which is based on native tissue, human tissue, is for sure useful to investigate the effect of this movement on the at cellular and tissue level. As well, the tissue engineering can help to have more information, to have more sample, to understand how rehabilitation is working. And finally, for sure, OActive project approach can allow to design a personalized rehabilitation regimen to reduce or even reverse tissue damage.
Thank you, Roberto. Do we have any questions?
No, Iana, by far. I don't know if anyone wants to ask something. Please use the chat box.
There is one at the chat.
Apologies. I don't know if you can read it. Can morphology of the engineered construct can be assessed using...
Yes, I can read it now. Yes, the answer is yes. We already did it during the realization of 3D construct. We used micro-CT to evaluate the porosity degree inside the mesh of the 3D construct. So the response is yes. The answer is yes, and it's very useful.
Thank you. If we do not have other questions, we can move to the next agenda item. I would like to invite Dr. Georgios Germadzis, last but not least, from University of Patras, to present the real-time gait monitoring and retraining.
So I hope that you can see my screen right now.
Yes, yes.
Okay. So let me introduce myself. I'm Georgios Germadzis. I'm a postdoctoral researcher in University of Patras with a background in physics and sports science, and biomechanics. And I'm going to present you today the work that we'll be doing in the University of Patras within the context of the OActive project. And it's about the real-time guide monitoring and retraining tool that we've been developing here. So a little bit of background. Some of the stuff you heard already from David Blitzman and his really nice presentation on the biomechanics of the disease. So let me just recapitulate a little bit. So it's we're talking about the knee osteoarthritis, and its onset and progression is by far related to mechanical forces. And especially the cartilage degeneration is affected by the mechanical loading during different weight-bearing activities like walking, running, etc. And it's unfortunately it's a non-reversible disease, so we have to find ways to maybe not reverse it, as I said here, but maybe stop it, and you can reverse it with pharmacological maybe interventions and surgical interventions. So one of the main things that we'll be dealing in the literature from let's say an exercise perspective or how we walk is the reduction. The aim is to the reduction of the knee medial torque. Okay, so it's as you can see in the picture on the right on the right screen on the right, it's this knee medial torque is caused by the ground reaction force. So the ground reaction force, we use this in biomechanics this is the force from the ground as you walk, and this is the ground reaction force. And this ground reaction force creates a torque, which is called knee adduction moment around the knee joint. Okay, and as you can see in the picture, the medial part of the knee joint is affected by far from this torque. Okay, so that's why mainly you have the mechanical forces and you have the degeneration in that particular compartment of the knee. So ways to reduce this medial torque is usually some braces, so some hardware devices that you can put on your knee, as you can see in the picture on the bottom, that you can, let's say, decrease this torque, this moment that it's causing the joint. Yeah, it's really difficult in terms of adherence level. So people they should wear it the whole time. So it might be impractical, and that's why research has focused on different kinds as well, different ways to reduce the knee medial torque, such as guide retraining. So how does it work? Okay, so how can I reduce the knee loading? There are different ways that you can think about, and they all rely on a simple concept that you need actually to decrease the distance between the ground reaction force vector, as you can see in the picture on the right, and the knee joint center. So there are different kinds of ways that we can think about. So you can increase the walking base. So during walking, you can keep your legs apart a little bit more than usual, and that seems to decrease the knee medial torque. Another way to do is a toe off. So you can walk with a little bit your toes outwards. So that's another way to reduce the knee moment. And also you can lean the torso sideways as you walk. So go from the right to the left and vice versa as you walk. And that also seems to reduce the knee medial torque. But the main issue of that is that this is, especially the last one, you can think that this is really uncomfortable to do. And it's not really sustainable in the long term. So we have to find an optimal way and might be a combination of the above, or even someone can think of more ways to reduce the knee adduction moment, the torque. That's the main drive behind our research. So in order to make a change in walking strategy maintainable, so how can we do it? So we need some type of a system that provides guidance and feedback, okay? And this has to be in real time, because you have to think about that a human can adapt their strategy not just by guidelines or our guidelines, and then you leave the clinical center and then you have to, just follow the rules of how you walk. You need a system that provides real-time feedback on how you walk. Especially the guidance can come from the system. We will talk a little bit later about that, or from a clinician. So you can have a clinician that has your information in real time, and then he can give some guidelines on how to perform better, let's say. Of course, the system should be attractive at the same time for the user, and it might be a clinician or the patient, and it has to include some kind of gamification elements in order to be, fun to use. So our approach is first, we have to come up with a solution of how to calculate the knee forces in real time. Okay, so you've seen a little bit from David how he presented how we calculate the knee forces, and so I'm not going to go through these details again. Just going to say that at this point we need a motion analysis lab, so we need markers and ground reaction forces. So as you can see, there's in this picture, you have a person that has some markers and he walks along the pathway with a force plate, this rectangular here, and we would take this information and we'd model the musculoskeletal system. So roughly it includes a fitting virtual model. As you can see, a box here. Let me break again. And it fits a virtual model to each patient, and then it calculates the joint angles, the joint torques, calculates the muscle forces, and calculates the joint forces. And it has to be done in real time. Okay, so it's we're talking about milliseconds here. At the same time, you need a visualization system. So we also implemented a three-dimensional visualization system. So you have all these analyses that you've seen before, the skeletons, which is the software practically, but we need a more sophisticated way. So you need, in this system, again, the skeleton, the muscles are reproduced every frame. Okay, frame, I mean the recording, the motion capture data, the recorded in frames. Okay, it's like a video. And the muscle geometry is improved based on muscle points from OpenSim. OpenSim is the modeling software that we use. You will see in some really nice videos that we've made before that the muscles, you can see them changing their colors and based on activation levels. So you have this kind of information as well from the OpenSim. And everything is updated for every frame. This system has really nice embedded functionalities as well. So you have you can have different kinds of metrics that you can visualize and other forces that you want to visualize, or either can be internal or external forces. You have some basic gamification elements at this point, and which are amplified as well, this gamification, by different type of scores based on performance criteria, and this is a work in progress. So I can play a video to showcase a little bit what we've been doing so far. So as you can see here, on the bottom right, you can see the person standing on the force plate. Okay, and at the same time, you can the larger portion of the screen is the skeleton. Okay, that it's moving in 3D space. The back engine does all this calculation and the modeling, and you have the forces in real time. Okay, so this arrow here, let's say it's the knee force that has been calculated. Okay, and on the right screen here, you can have the metrics that you can visualize. This is the knee R and the knee L, so it's the knee forces on the right and the left, and you can see, because it's only the right leg, So you see only forces on the right. Okay, and then you see the blue here is the knee angle, which is in rad. We tried now we have it in degrees. And we will see some other videos as well later on. So as you can see here, and maybe we'll see the next one as well. So a person walking. Okay, so again, the same visualizations here in different motion. Okay, and you can see the different colors and stuff. We will explain it later. So I'm going to share you a nice video that we have with all these functionalities that I've said until now. I don't want to tire you because I'm the last one, and always the last one has a tiring audience. So yeah, hopefully you will enjoy the video that we've seen, and I'm going to pause it in parts so you can see the deep functionalities here. So yeah, I'm going to pause it a little bit here. So you can see here we have a person walking on a treadmill, and so it's in continuous motion. And this is the main screen that the clinician will, this is the desktop application. Okay, so the clinician sees a person here walking, so it's a representation of the lower limb. Okay, so you have the different muscles here. So, and then you have different forces, the ground reaction force, which is in blue, and then the knee force, which is the orange. And you have some kind of bar, like a performance criteria, not performance, but it tells you the magnitude of the force. And then again, as I said before, here you have different metrics that you can visualize, the colors and everything. And also you have a top view of the area, which is really important because you have some really nice information on the key biomechanical parameters that you're interested in, such as the stride length. So it's like a half-meter stride length. It's really important that sometimes if it has been shown that if you decrease your step length, your stride length, then you can decrease your joint forces. So that's another strategy that you can follow. Here you see the base of the walking. So also you have a metric here. You will see it later. And then you have also, you see the angle here regarding the toe off strategy that we said before. And you see the angles, like how much the foot deviates from the vertical line along the foot. So maybe play a little bit of the video. Yeah, again, you can zoom and you can see, yeah, you can see live. So you have the skeleton visualization module. You can have it's a 3D representation. As you can see here, the numbers are changing here, stride by stride. And also important, as I said before, you can see the different activation, the coding, the color coding of the important muscles, and they change colors while they're activated. So red is the color of an inactivated, and you see as soon as they activate, it goes from orange to yellow. Okay. Muscles are procedure generated, it's trained based on the muscle path points provided by OpenSim. So the back engine provides data in every frame. Okay. And it's really intuitive in terms of visualization. Yeah, as I said before, yeah, the activation is highlighting the muscle with an overlay color, and it's and you can select, and you can have joint and ground reaction forces as well visualized here. It's important is that you just you have a vector, so you can see the direction of the force as well. So that's an important aspect of some physiotherapists might be interesting to see as well. So for that system to work well, you need some kind of continuous motion in order for the training model to have an effect. Yeah, and now we will show a little bit of how the different options of the interface here. So let me pause it a little bit. Maybe, yeah, so here. So you can select different muscles, and you can select different reaction forces. You can scale them here, the different functionalities. So the width, so it's a different, if you change it, then you will change the scale, let's say the margins, the limits. Also the bones here, you can see different kinds of information. And you can select the graphs here. So the names are intuitive. So it's a force magnitude and it's an ER. So you can select it, and then you can name the plot here. You can select grid lines, enable or disable legends. If you want to round Y values because you have a lot of it's big numbers. Oh, sorry. Okay, and then you can select the different colors here that you want to choose for the visualization purposes. You can name the plot as well. And as you can see here, how the system is being updated on the fly. Okay, different kinds of moments, because I said to you at the beginning, we need that type of information in a basic level, the knee adduction moment. So here you can, or abduction or adduction, it doesn't, it's the same thing right now. It's not the same thing, but the terminology changes sometimes. So here you have on the fly the ground reaction forces and the knee moments that they are calculated. Okay, and everything is being done in real time. And also now the gamification approach. So you need some kind of indications of performance. So here you can have a simple metric that you said, okay, let's say that the value that it's average is 1,500 for the, let's say, the force, and you can see how it changes through time. And also you can select some other intuitive graphs for some other things. So you can see here, oops, it's fast. Okay. Yeah, you can select the right and left leg as well. You can have some indicators here or here. So it's red if something is going, you don't do it right. So the clinician can set a predefined value for a metric that wants to monitor. And then if it goes above that value, then it's red. So it's, it's an interactive process, and everything happens on the fly, and you can guide the patient appropriately and see the effect of your guidance in real time. Of course, also there is the augmented reality aspect of that, especially from the patient perspective. Okay, so the patient perspective doesn't see all this visualization and functionality that I've shown before, but wants to see a simple gamification element of the above process. So let me play this video for you. So using the goggles, the augmented reality goggles, you can see, you can select which kind of visualization element the patient will see. So you can transport the plots or the bar or some kind of other gamification element that you can choose, and just tell the patient to follow a simple graph or a simple bar, taking into account. So, or just trying to move and follow some scores based on some performance criteria. The next step is to also research on the outdoor solution. So right now I was describing an indoor solution that you need a motion analysis lab to do this kind of analysis. But in a clinical setting, this might not be the case, and the the availability of a motion analysis lab is a factor that inhibits this kind of this kind of training. So we want to see how we can use IMUs, so inertial measurement units. So these boxes here, placement on top of a body, and then use this data to have in OpenSim, the modeling software, so you can have the same kind of analysis in the modeling software, but not using the motion analysis lab, but using the IMUs as input data. And then the rest of the analysis will be the same. We are working on that direction as well. So yeah, so that's, you can see here. So that's thank you a lot for that's it. So thank you a lot for listening, and I can answer to any questions you might have.
Thank you, Yorgos.
Okay.
Marinella, I think we have some questions.
Yes, just give me a second to share my screen.
So from Marius, there's a question. Contralaterally or ipsilaterally? I think it's contralaterally. So contralaterally or ipsilaterally, I think it's from the same, like you walk on the right leg and you lean on the right leg on the right way. So I think it's ipsilaterally. Yeah, the way that you can decrease the knee moment torque. But I think that's the kind of movement that you don't really want to tell a person to follow, because it's even for really fine and subtle kind of movement, it's really uncomfortable, and I think it's unfeasible for a person to follow this kind of torso lean. But it's a strategy, and it's been proven. So okay. And then from Bryce. Assume there is some simplification and splitting of values from OpenSim to allow this to work in real time. Have you compared your real-time results with those you get from offline processing? Actually, we did. And that's actually, this will be the kind of validation that we need. And it's working really well for, you know, of course, you might know that as the mathematical problem advances, the errors advance as well. So in the kinematics level, it's really the results are really good in terms of you know, accordance. Okay, between the curves, the kinetics, then the torques, you have a little less correlation. And then the forces, even less correlation. But I think that we're working on that a lot. So we have improved our the prediction, the calculations from the real time and the offline calculations. So they are really good agreement. And yeah, that's really promising, because you have to see the overall context, which is that it's not really an accurate research that we'll be doing here in terms of the real-time monitoring, but you want to see the effect of the motion strategy to the knee forces. So it's not really the point that you need to calculate really accurate comparing to the offline calculations, but I have to tell you, it's really close. But you want to see the effect. Okay, so you really want to see from that tool how it decreases or increases in a certain motion strategy, and that it's really something. I think that the main challenge here is to do it in real time, and yeah, all the calculations. So you need some kind of simplifications in the static optimization and the joint reaction, especially in the static optimization, which is the heaviest, let's say, part of the calculations.
Thank you, Yorgos.
I hope I answered the question.
If there are no other questions.
No, Joanna, we can
Okay. So I would like to thank you all for your presentations and all the participants for showing such an interest in OActive. I should not forget to thank also the Axia team for their help during this meeting. I would like to remind you to visit the OActive website and subscribe to our newsletter. And now, in order to give us your feedback on the training session, we are using the Slido platform. So you can go right away to slido.com and add the password 16988. I will share my screen. Before you leave, you can give us your votes here. So here is again on the left the address slido.com and the password 16982. I will give you some time to go there. You can also scan the QR code. And the first question online now is, how did you find out about the OActive training? Was it through the OActive social media? Was it through the OActive website? Was it an email invitation? Or if none of the above applies, the other? As I can see, the OActive social media is the most popular answer so far. We are happy to hear that. There are two more simple questions, but I will give you some time to vote for this one. There are multiple choice questions. I will move to the next one, which is, what attracted you to the OActive training? Are you a family, a patient's family member? Are you a patient yourself? Are you an athlete? Do you have a similar research interests, or do you have or are you a healthcare provider, or other, if none of the above applies? We have, as I can see, representation from different target groups. You're happy about this also? Let's move to the last one. Did you find the training interesting? I will reveal this answer even to ourselves after we collect all the answers. It is important to us to see if this was useful to you, so please vote. So we are 33 now, in, and 35 counting, and I'm happy to see that you've all found the training interesting. Thank you for this, and thanks to all presenters. I will move to the previous questions for those that have now joined, and I will give the floor. You can vote, of course, as we speak, but I will also give the floor to Professor Felekis, the project coordinator. I can say a few words before closing the session. Kyriakos, the floor is yours.
Thank you, Anna. Would like to thank everybody, all of you who participated in this training session. It looks that you find it interesting. On behalf of the OActive Consortium, I would like to thank all the presenters here for presenting their work, and especially the colleagues from Axia Innovation, from the organization and putting this together. Thank you very much, Joanna. You can, as Joanna said, you can follow any developments of the project through the website and through the social media, where you will find all the open access data there, as well as publication from the OActive Consortium. And we will be glad to answer any questions, specific questions you might have through these platforms. Thank you all. Have a great weekend and stay safe.
Thank you all. Bye-bye.